Start the recording, and we're now recording.
Okay. Well, good morning. I'm Kathleen Borain, and I serve as the Maryland Insurance Commissioner. Welcome to the 7th public meeting of the MIA's Network Adequacy Work Group. This group was convened to consider revisions to the MIA's 2017 regulations, establishing standards and reporting requirements regarding the sufficiency of carrier-provider networks. Draft regulations were published for comment in November of 2020, and we have had several meetings to discuss the draft regulations and comments received with respect to them. Today, we are focused primarily on the treatment of telehealth access in the context of network adequacy compliance. As we get started, I'll go over a few housekeeping procedures. First, this virtual hearing is being held via the Zoom webinar platform and is being recorded. The video and sound recording will be made available on the MIA's website within the next few days. Second, only those individuals who received a panelist invitation and who have accessed this meeting through that link can be seen or heard. Links were sent to the individuals who requested to speak in advance. If you fall into that category, but you've not been able to log in as a panelist, please let us know via the chat feature and we will move you over. Third, even if you did not sign up to speak, if you wish to be heard, please let us know via the chat function. As time and technology allow, we will call on you in turn and unmute your line to allow you to speak. We really do want to hear from everyone who wants to speak, so don't be shy. To help ensure excellent sound quality, though, throughout the meeting, we ask that you please stay on mute unless you're speaking. So now I'd just like to take a moment to introduce the members of my staff who are participating with us today. And I will say a special thanks to all of them because today is a state holiday, but they graciously, my entire team, agreed to participate today because this is an important meeting. And we are so grateful and respectful of the time and the commitment of those individuals who agreed to present today. And of course, to the people who are, dialing in and will engage with us on this topic. So as I say, a special thanks to all the members of my staff who are with us today. And let me introduce them. Corey Boone, who many of you now know is my relatively new Chief of Staff. David Cooney, the Associate Commissioner for Life and Health. Erica Bailey, the Associate Commissioner for Compliance and Enforcement. Lisa Hall, Deputy Counsel. Lisa Larson, the Director of Hearings and Regulations. And Craig I, the Communications Director. At our last meeting, which was held on May 28th, we concluded the section by section discussion of the public comments that were received on our November 4th, 2020 draft revisions. As noted, today's meeting is really focused specifically on the role of telehealth in network adequacy. Telehealth has already been one of the primary topics of discussion throughout these work group meetings. But as you know, the Maryland General Assembly passed Senate Bill 3, the Preserve Telehealth Access Act of 2021 earlier this year, which specifically directs the MIA to consider the requirements of the act when proposing any revisions to the network adequacy regulation. The act also directs the MIA to study the impact of recent changes in telehealth access and coverage on the ability of consumers to choose in-person care versus telehealth, and how telehealth can support efforts to ensure healthcare provider network adequacy. So in consideration of Senate Bill 3 and our own ongoing efforts to understand the best way to fit telehealth into this discussion, today's meeting will include presentations from carriers and healthcare providers on telehealth utilization trends and patient and provider feedback on the telehealth experience, as well as an open discussion on the appropriate role of telehealth in enhancing networks efficiency. And I hope that everyone had the chance to review the sort of topical questions that were posted to lead that discussion. So with that, let's start today with our first presentation. And we are very pleased to have joining us this morning, Dr. Raul Tripanini, who is the Associate Mental Health Director at Kaiser Permanente Mid-Atlantic. Dr. Tripanini, thank you so much for agreeing to participate this morning. I understand you also have Dr. Fazi Sabi, the Associate Medical Director, with you to answer questions. So welcome to you, and we look forward to your presentation.
Good morning, Commissioner Borain and the rest of the MIA team and all the rest of the participants. It's really a privilege, and thank you for giving me an opportunity to speak. I'm trying to share my screen. The host to disable the participant screen sharing. I believe you folks need to allow me to share my screen.
Yeah, Craig can do that.
Right? Are you? I guess.
Yes. Let me see what I can do here.
Yeah, while Craig is working on allowing the panelists to share the screen, I would like to introduce my colleague, Dr. Fawzi Sabi, who is an associate medical director at our Mid-Atlantic Kaiser Permanente, who actually played a very key role in the expansion of the virtual home care program that was developed right after the COVID surge to enable our organization to treat patients who are infected with COVID and who are either coming out of the hospital to recover, or the ones who are not sick enough to be in the hospital, as a way to promote the social distancing and making sure that the patients are getting the right kind of care. So she is going to be joining us to answer any questions regarding that. As now I think I can share my screen.
Yes.
I'm sharing my screen. Give me 1 second. Can you all see my screen?
Yes, we can.
Okay,
Thanks,
great.
Craig.
Okay, let me go ahead and share. And I'm sure you are all aware the pandemic has really forced the entire healthcare system to rapidly adapt to the telehealth model of care. And also it gave us a huge opportunity to decide on what's possible and what is desirable and what kind of models of telehealth care can be adapted in the rapidly evolving situation at the time. This telehealth, of course, has helped us to both directly and indirectly in reducing the spread of infections, because we can maintain infinite social distance, and also it provides safety to the providers and also at the same time to the patients. Of course, the telehealth also is another solution that has been in evolution slowly over many, many years, even within our own organization, to promote self-management skills to the patient. And that's steadily growing because we have increasing number of patients with the chronic illnesses and who may have difficulty in transportation to be able to come to the traditional healthcare delivery organization. So the telehealth was taking a key role to allow the patients to get the care even when they are living in a geographically distant locations. So in my presentation today, I'm going to primarily focus on these 4 topics on telehealth utilization trends within our own organization, and what kind of feedback we have gotten from our patients regarding their satisfaction, and what are our barriers to access, and what are our own learned best practices for tracking and measuring the telehealth utilization. Telehealth is not new for Kaiser Permanente. We have been adapting telehealth for more than a decade. You can pretty much summarize telehealth into 4 subcomponents. One is synchronous telehealth, which is the real-time transmission of telehealth technology, wherein you are providing an integrated video visit. And we have that in place since 2013 in Mid-Atlantic Kaiser. And the second component is the asynchronous telehealth, wherein you store and forward. A classic example is a digitizer PAC system that is used in radiology. And since 2015, we have implemented teledermatology, wherein patients can come to a primary care physician, and a primary care physician's office can take a picture of a dermatological lesion and send that picture to a dermatologist, who will be reviewing the picture along with the history and making a recommendation to the primary care physician, if it is appropriate, of course, in real time. But during the last several years, the explosion of the smartphones and the quality of the camera phones becoming very good. And we actually opened our system wherein patients can actually take a picture of their own lesion from their smartphone and directly send to our healthcare setting, wherein that picture can be reviewed by a dermatologist and make appropriate recommendations as long as the quality of the picture is adequate enough for a dermatologist to make a reasonable diagnostic assumption. And of course, with the pandemic, our telehealth utilization has tripled compared to the pre-pandemic. And the third area that we already started implementing within our own organization during the last 4 to 5 years was the remote patient monitoring and wearables. This is where Dr. Fauzi's team has been involved in managing our chronically ill patients. With the recent pandemic, we have been able to give the pulse oximeters to the patients who are recovering from COVID, so that you are monitoring to make sure they have adequate oxygenation in their body, and then tracking their oxygenation, which was a huge win, so that you are not risking the patients to travel while they are recovering from COVID. And the fourth component of our telehealth utilization is our mobile app, which probably I won't go into too much detail today. So what happened during the pandemic with the telehealth? I mean, of course, we went through many phases of telehealth utilization trends. Of course, the pre-pandemic in our mid-Atlantic, we were probably providing close to 10 to 12% or 12 to 10 to 13% of the telehealth care. And the video visit care, even though we launched in 2013, but relatively it is a small percentage, about maybe 2%, of course, in roughly 2%. That translates to maybe about 250 to 275 visits a day. And then, of course, we had the initial crisis with the shutdown of the entire state or entire country around mid-March when the COVID hit. And our video visits rapidly jumped to about 25%, literally within a matter of a week. That is almost tenfold increase. And of course, the in-person care plummeted to 10% for the right reasons. And then again, we had another summer surge, which was the initial surge. And we continue to expand our mid-Atlantic video visit and telehealth utilization, which reached to the peak of close to about 70%, whereas about 30% of the in-person care started to slowly reemerge back. And I guess in the fall of 2020, and then we had another slow beginning surge. And then at that time we had, but however, during that time, we have not seen a decrease in our office visit utilization. So we pretty much around stabilized around 50% of the office in-person visits, and about half of them are telehealth visits, out of which 25% are video visits and about 25% are telephone visits. And you all realize that we had a third surge again during later part of the last year and the early part of the 2021. Nevertheless, even during the third surge that we had, our in-person demand for care started to continue to slowly increase. And in the spring, once we had the vaccines, and then people are starting to get vaccines, we started to gradually see an increase in the care, either that was driven by our own physicians because of the clinical need and necessity, or because patients are wanting to be seen because probably they feel that they needed to get the care that has been suppressed, or they were putting it off. For example, a physical exam or other types of preventative care examinations or procedures that they were putting it off, they were starting to come back. Now we have kind of stabilized it around 60 to 40. 60% of our care is now roughly in-person care, and the rest of the 40% is about telehealth care, which is kind of equally divided between video visits and also the telephone visits. This is to just give you by numbers in what our experience has been in the 2020, wherein about 10 and a half months of experience since the pandemic hit us around mid-March. Right now we are about half and half. But what I would like to really want you to pay attention to is we were providing roughly about 3.5 million visits on average per year. But in 2020, we provided about 4 million visits, out of which 2 million are office visits and 2 million are telehealth visits. But what's the key difference in 2020 was our video visit utilization increased by 14 times compared to where we were before in 2019. So on an average, we at Mid-Atlantic Permanente, we are providing roughly about close to 4,000 plus video visits a day. We topped 1 million video visits right in 2020 itself, in addition to all other video visit applications, and also the virtual home care program and in-home care program that Dr. Sabi has led and spearheaded within our organization. They were an invaluable piece of the entire telehealth care, and that rapidly escalated to close to 50,000 visits in 2020. So this is our trend of our utilization of the 3 visit types. Each is marked in 3 different colors. The office visits are in orange color, telephone visits are in green color, and the video visits are in red color. So it goes back to October. October is pre-pandemic, and from pre-pandemic, we were running around roughly close to about 15% of the telehealth visits, whereas the video visits are only about maybe 2% at best. And look at what happened once the pandemic shut down. We have rapidly escalated our video visits to almost to close to 25 to 30%. And the overall telehealth volume at one point reached about 90%. And now the telehealth started to slowly decline. And in the month of May, we stabilized at around 60-40. If you can see in the last bar graph you have here, 60% is reflective of the entire office visits, and 20% is telephone visits, and 20% is video visits. But this data is for all the ambulatory clinics setting of every single specialty, that includes all the way from allergy department to urology department in an alphabetical order, which includes the behavioral health. But however, I wanted to share this. Behavioral health is a completely different domain. In behavioral health, we are by the way, I am a practicing child and adolescent psychiatrist, and I practice part-time. Behavioral health actually opened up the doors and gave an enormous opportunity to expand on the telehealth, because we don't need to touch the patient. And we primarily interact with the patient visually, which is very, very important, so that we can engage with the patient. And if you look at our telehealth utilization, in pre-pandemic, we were running about 8 to 10% of the telehealth utilization that is pre-pandemic. With the pandemic shutdown in the month of March, we rapidly pivoted our care and escalated to primarily video visits. And we are now providing roughly about 80 to 85% of the entire behavioral health care through video visits. And if you combine a small portion of the telephone visits that we provide, at this point, the behavioral health departments of our Mid-Atlantic, that includes both care provided by psychiatrists and also psychotherapists, about 90 to 95% of the behavioral health care is primarily provided by telehealth. And we do expect, we are beginning to see, by the way, we do give an option to every single member. If they would like to be seen in person, they're always given an option to come in person. As an integrated care delivery organization, which is Kaiser Permanente, which is a nonprofit organization, we don't bill, and we are not a fee-for-service organization. So we do not have any incentives to provide a specific type of visit to get more reimbursement. Our goal is primarily to provide what is suitable and what is best, that meets the needs of the patient to provide the better outcome, and also what are the patient preferences. So in a way, we are slightly different from other organizations, wherein the type of care that they might provide could potentially be driven by reimbursement by the third-party insurers. And then I wanted to share some data on our patient satisfaction. Even before pandemic, even years before, we have been measuring satisfaction from our patients. We do conduct what's called a member patient satisfaction survey, which is a very large randomized sampling that is sent out to patients. And then we dissect the data based on the patient satisfaction for both the telephone visits and the video visits and the office visits. Since I wanted to share the data on the quarterly trending, here from pre-pandemic to the most recent quarter, which is Q1, which shows the patient's perception of their satisfaction with their physician or other healthcare providers, because we have a lot of other healthcare providers who are not physicians, like nutritionists, optometrists, and behavioral health clinicians, and physical therapists, all of them. So if you do look at the green line is the satisfaction trending of the video visits, whereas the blue line is the satisfaction trending of the doctor office visits, wherein the patient came to see the doctor in person. Even though there was a slight dip in the doctor office visit satisfaction ratings in Q2 at the peak of the pandemic, because our sample was so small at the time, but in general, if you do look at the video visit satisfaction and doctor office visit satisfaction are almost the same. They're almost identical. So patients are as happy as they are when they see the doctor in person or when they see the doctor through the video visit or any other healthcare provider. But however, take a look at the telephone visits. The delta between the telephone visit satisfaction and the video visit satisfaction is large enough, and it is statistically significant, which is almost at 10 percentage points. By the way, we measure satisfaction on a Likert scale of 5 ratings: poor, fair, good, very good, and excellent. These ratings are only for patients who give excellent only responses. So our bar in measuring our patient satisfaction is very high. We only measure the percentage of the patients who gave excellent only satisfaction ratings. And then we also ask another question in our member patient satisfaction survey during that visit that the patient has completed, whether they feel like their needs are met. This is only patient's perception of how they feel that their needs are met. This gives a very interesting data. If you look at the doctor office visits, which is the blue, which is somewhat in the middle, and look at the telephone, which is always at the bottom, whereas in the video visit satisfaction actually ranks the highest, wherein the patients are feeling like their needs are met, whereas the telephone visits rank the lowest. Why do we slice the data like this? Because this type of data is helping us to drive our operations, how best we can promote more video visits. And granted that we do realize there is a small subsection of patients who may not be able to join video visit. This data really helped us, especially in our behavioral health department, to drive our video visit health utilization to almost 85%, which is probably unheard of in any other organization. And then we have another most important question in our satisfaction survey, which is to measure whether that particular appointment that the patient had, whether it is an office appointment or a video appointment or a telephone appointment, met their needs and schedules that were taken into consideration when they scheduled the appointment or when the healthcare organization scheduled the appointment. Here it is a no-brainer. Video visits rank the highest, wherein patients are most happy because they don't have to travel. It is a lot safer for them to have a video visit. And the delta between the video visit satisfaction for needs and schedules is almost 13 points higher than the office visits or even the telephone visits. And then we also ran the satisfaction trending for needs and schedules and whether the patient's needs are met for behavioral health visits. This includes all visits with the psychiatrists and psychotherapists. And in the blue line represents the doctor office visits, and you don't see data points for 2 quarters in 2020. The reason because we didn't have adequate sample size that is statistically significant to report out the data, but we did have enough data for Q1. And here also the message is the same. Patients tend to have much lower perception that their needs and schedules are taken into consideration when an appointment was scheduled for an office visit versus when they had a telephone visit or when they had video visits. Patients in behavioral health are a lot happier with a telephone visit or a video visit. Moving on, we also wanted to understand more about digital divide. There are differences between different patient segments, because we have to be cognizant of there is a digital divide among our communities. And first, we looked at the data from the 2021 year-to-date data for the last 5 months, and looking at the differences between the visit type distribution between the 3 lines of business. We divide basically the lines of business into our commercial segment and our Medicare segment and our Medicaid segment. And if you do look at the Medicare segment has the lowest video visit utilization, but if you do look at the overall office visit utilization, it is more or less the same. So there are definitely opportunities for us to be able to increase the video visit utilization, because Medicare membership, probably because of the age or technology, they may not be as comfortable with the video visits. They tend to lean towards much higher proportion in the telehealth utilization to a telephone visit. And then also we wanted to look at whether there is any digital divide among the racial distribution. So if you look at the racial distribution, we do see some differences, but not a whole lot as we expect. The Hispanics tend to have the lowest video visit utilization, whereas of course the whites tend to have the highest video visit utilization, almost at close to 30%. But if you combine the telephone visit and the video visit utilization, the whites tend to have almost close to 50%, close to 48% of the telehealth utilization, whereas Hispanics tend to have roughly at lower of 41% of the utilization of the telehealth versus close to 60% of the utilization for the office visits. And we really don't see a huge difference between blacks and whites. And the Asians also tend to have somewhat closer to the utilization of the telehealth to the blacks. So this kind of helped us to look at what else we could do operationally in promoting and overcoming some of the barriers related to the digital divide. And then I wanted to, before I sum it up, and I wanted to share what really helped our organization, our Mid-Atlantic Kaiser Permanente, to promote the telehealth utilization, especially the utilization of the video visits, which we find most helpful to our members because they are much more effective and patients are a lot happier with them. We have constantly engaged in our training, and we have technically solved our problem issues with our providers. And even before the pandemic has set in, I would say roughly around 2016 or 2017, every single one of our 1,600 Mid-Atlantic Kaiser Permanente physicians have the capability to activate video visits remotely, because they do have the laptops and they have the secure VPN platform and the home monitors, and the whole equipment was already given to all of our physicians. And we have a lot of training. And of course, with the pandemic, we have accelerated and we repeatedly trained our physicians. And one of the huge advantages that we had in our Mid-Atlantic region was also our video visit platform is integrally incorporated into our electronic medical record, which is Epic. Mid-Atlantic KP has been using Epic for more than 15 years. So our video platform is not a standalone platform like Zoom or other third-party commercial application. It is totally integrated into our electronic medical record. That also makes our video visit platform a lot more secure. And in addition, we also have an ability for our providers, while we are on the phone with the patient, if the patient has a smartphone, we can instantly open up our video platform from our electronic medical record and send a text to our patients so that the patients can actually join a video visit on the fly. And in fact, I have done that many times for my own patients, and that actually works very well. And the patients are so pleasantly surprised how easy it is for them to join the video visit. And our constant messaging to our patients during our after visit summaries, if in case we could not do a video visit, and also during the telephone conversations the patient may have with our receptionists or scheduling clerks, is to always promote video visits wherever and whenever possible. And the other reason why we have done very well with our telehealth utilization is we share our utilization data with our stakeholders. We share unblinded data by department, by individual physicians level, so that we can find out who are our best practice, who are our physicians who are best utilizers, what are they doing differently from the ones who don't utilize the telehealth, especially video visits as much. And then we do share, and also the leadership is also actively involved in promoting the telehealth utilization so that we are walking the talk to our what we are doing. And we do expect this telehealth is here to stay, because the pandemic definitely opened a huge opportunity for us in terms of what is possible, as I was talking about earlier. And I wanted to share, this is my last slide, and I wanted to share the JD Power did a telehealth satisfaction survey with the randomized sample across the country that was done pretty late into the pandemic in the November of 2020. And they were asking members, what are the top 5 reasons why you want to consider using the telehealth? This was the time the pandemic is slowly receding and the vaccines were slowly going to come back into the market. The top 1 reason patients want to use a telehealth is convenience, especially the ones who are geographically located in the rural areas. This is unbeatable convenience. And safety, because it is also a lot safer for the members, because telehealth utilization provides that level of safety. And the speed, ability to receive the care much more quickly, because you can have rapid access. And the quality of care, the way the patients perceive that their needs are met. And if you recall in the data slides that I presented to you earlier, this is exactly what we found from our data, that the patients are feeling that their needs are met with the video visits, especially more so than the telephone visits. And of course, the last reason why the patients want to use the telehealth is conditions that are covered by telehealth visit. This may be applicable for a fee-for-service environment, because some fee-for-service environments do not reimburse telehealth visits at the same rate as office visits, which is a moot point in our integrated system, because that would not apply, because the patient's payment has nothing to do with us. Ours is a prepaid health maintenance organization, and we provide the care, whatever the modality that the patient needs and what is required, that can lead to the best outcome. Oh, Craig, I'm done.
Well, thank you. That was impressive and extremely informative. You answered actually many of my questions as you went along. I what was very interested in things like what was driving, choice of location, but you've indicated that seems to be, meaning by location, I mean whether it's an in-person visit or a telehealth visit, video or telephone. As between video and telephone in that breakdown, what do you find is the primary driver there? Is that also patient choice versus availability? And we can talk about patient choice in terms of equipment availability, but is that primarily patient driven or provider driven? Which of those telehealth methods?
That's a great question, Kathy. I think it is driven by both. And we are, as an organization, we knew the data. We knew that we can provide better care with a video visit, because we can engage the patient. In fact, I can share my own experience. When I can see my patient, whether it is a child or a teen, along with their mother, parent, as a part of the visit, I can engage, I can visualize my patient, and I can see what's going on as a psychiatrist, because I can better assess. But if I'm on the phone, I cannot assess as well unless I had established a relationship with that patient even before. That's in my field. If you take another a medical specialty like an endocrinology or maybe rheumatology, a physician can actually see the patient and could ask the patient, could you raise your hand? Could you open up your fingers? If you have arthritis, I wanted to see what is the range of your motion on your wrist, or range of motion of your fingers. So physicians can actually better assess the patient. So in a way, we are driving to promote video visits as best as possible. Granted, we do realize there is a small section of the patients wherein video visit may not be ideal or may not be appropriate if you already had either a video visit or if you already had an in-person visit. If you're calling the patient to just share the results of a test or discuss a treatment plan with already pre-established patient-doctor relationship, a telephone visit can easily replace a video visit. But especially when you are truly trying to develop a relationship as a doctor and a patient and truly assess the patient, video visits by far the most preferred visits. And what all patients needed to have to join a video visit either is a smartphone, iPad, or a computer. And of course, nowadays, who uses computers at home? It's basically a smartphone or an iPad. And on our setting as a healthcare organization, every single healthcare provider has a full setup of the video visit capability, not only in their offices. With the pandemic, they were provided the entire kit, including a VPN secure portal so that they can use their home Wi-Fi if they are joining a virtual visit from their home. So that the provider, on a provider issue, the technology is not a barrier on our end to any one of our 1,600 physicians.
So I thought that the charts on demographics were very helpful as well. One additional question that I had was with geography. So when we talk about digital divides, we also have to talk about sort of, broadband capabilities, stability, et cetera. And I wonder whether you all are doing some additional slicing and dicing in terms of zip codes and geographic areas, because not everyone has the connectivity. But aside from the equipment, not everybody has the connectivity that would allow them to engage in, certainly a video telehealth visit.
That's correct. Yeah, we are in the process of doing the data slicing by zip code. Yes, you did bring up an important issue of the broadband capability. And we have noticed, we do, of course, encourage our patients, if they are joining a video visit, they should preferentially join a video visit through the Wi-Fi network, because the Wi-Fi network, of course, gives you much broader capacity. And if they do not have the Wi-Fi network, and of course they can join through cellular signal, the cellular signal does work, but occasionally we have seen it does seem to freeze and it is not as stable as a Wi-Fi network.
Thank you very much. Those were my questions. Let me open it up to the other members of the MIA staff who are present to see if they have questions. David or Erica, no?
No, I mean, like you said, that was extremely informative. So I think a lot of my questions were already answered.
Erica, did you have anything?
No, not at this time. I think the issue of access, particularly as it relates to broadband access or areas in the state that may have customers or patients that are challenged in that regard, was answered in your question. Thank you.
Thanks, Erica. I know Dr. Salvi, you were on to answer questions. We didn't have a whole lot. I don't know if there's anything that you would want to add to the discussion or wanted to say today.
Thank you for having us. And, we appreciate the opportunity to share our experience with you.
Absolutely. Well, thank you all very much for a very, very thorough presentation. If you can make sure that we have those slides, we would very much appreciate having a copy of them.
Yes, we'll be happy to send it to Craig. Yes.
Yes. Thank you so much. So our second presentation this morning is from Allison Davenport. Welcome, Allison, who is the Senior Vice President of Optum Behavioral Health, who will describe some of the telehealth trends that Optum has observed in the behavioral health sector. So Ms. Davenport, thank you.
Thank you so much, Commissioner. I'm very honored to be here. And I appreciate Dr. Tripernini's presentation. You're actually going to hear many of the same themes echoed in my comments. So I'll be brief. I want to talk a little bit about our experience with virtual care, both prior to the pandemic, during the pandemic. I want to talk a little bit about some of the early evidence bases that we're seeing around the effectiveness of virtual care. And then I'll spend a little bit of time covering how we're thinking about the future. Again, many of my comments you'll recognize, although Dr. Tripurani and I did not coordinate before, but I think we have a very similar point of view. So thanks again. I really appreciate that we started out talking about telemedicine, and not all telemedicine is the same. It's a very broad term. And as Dr. Tripurani said, it captures remote monitoring, it captures virtual visits. There's really a broad spectrum of telemedicine modalities. And so the experience that I'm going to be commenting today on, the experience that I'm going to focus on is telemental health and virtual care. And I would say, in addition to many of the topics that we've hit on around access and satisfaction, and the need to be sort of physically present with a patient for certain physical healthcare modalities, another key difference that I want to point out with virtual telemental healthcare is that the nature of the visit, the duration of the visit, and the experience of the visit is very much the same as in person. And that isn't always the same with physical health or more acute services that are delivered virtually. So an important distinction that I think we have to think about as we work together to set policy. Given many of the really wonderful flexibilities and learnings about access that Dr. Tripurani just hit on, we're very interested in and appreciative of being part of the conversation about thinking about access, because as he said, telehealth, telemental health is here to stay. And so we appreciate the thoughtfulness, Commissioner, of you and your team in constructing the regulations and the policy. So prior to COVID, Optum Behavioral Health was certainly invested in virtual care. We had a very large virtual care capable network. And that network was probably understated. We reported as providers who attest that they are using a HIPAA compliant virtual platform, and there were probably others as well. But that was something that we always offered, and certainly during COVID, we offered use of a virtual platform at no charge to providers to ensure that we weren't going to see a disruption in access to care, especially at a critical time. And of course, as the doctor said, considering payment rates and payment equivalency, particularly during the pandemic, so that we did not inadvertently create any policies that created barriers. So during COVID, and it's very interesting, the stats align, I would say aggregate nationally, all coverage types, virtual care probably accounted for about 2%, very similar to Kaiser Permanente's data, about 2% of visits. During the pandemic, and this is continuing, we exceed 50% on the aggregate. So very similar data to what Kaiser Permanente Mid-Atlantic is seeing. We see reflected across providers and across the country, with, of course, as he said, some differences in coverage type. Medicare adoption for our Medicare enrollees, not quite as high as for our commercial enrollees, but certainly higher than it was prior to pandemic. We also allowed for some expanded care delivery, IOP, PHP to be delivered virtually to really ensure that people still were able to access those. And as we think about the needs of people, and I want to just spend a minute talking about a problem that we're pretty concerned about, which is the evidence, the very, very clear evidence of psychological distress that exists in our communities and our populations now. When I look in particular at CDC data around communities of color self-reporting psychological distress, the month of August in 2020 to the month of January January in 2021, there was an exponential leap in people who are reporting symptoms of psychological distress. That is going to create a huge need and a huge demand on our system. And I think one of the things that I appreciate about the many psychiatrists, both who work with us at Optum Behavioral Health and who we work with across the industry, is that we have to turn our attention to the durational impacts of this pandemic. These are not simple conditions, simple problems that will resolve once people have a vaccination. And so we really need to be prepared as a community to address an emerged need and an increased demand for quite some time. And I think COVID has intensified for many people issues. We look particularly at substance abuse that may have existed pre-COVID, certainly intensified during COVID. I so appreciated Kaiser's data on satisfaction, because I've heard anecdotally from many of our providers about satisfaction, but I had never actually seen it broken out empirically in quite that way. And so I was fascinated to see that the preference for virtual over in person is very pronounced and clear. That's fascinating. Again, I've heard it anecdotally. I suspect it, but it was really great to see that reflected there. And we see the same, that people are satisfied. I would add, as we think about access, as we think about equity for populations that we serve, in doing some surveying with Medicaid recipients, one barrier that we didn't talk about yet that I think is important, and it's a little bit more nuanced than broadband access, is privacy. Privacy when you're having a virtual visit is important. And for many of the people we serve in public programs who live in congregate settings, that just isn't, that's not available. And it does create a barrier that we don't think about a lot, but we need to be thinking about and addressing. So I spoke just a minute ago about really the pronounced need that we're seeing, something I think as a community should be concerned about is practitioner availability. I wish that we could get more and more medical students to go into psychiatry, particularly child and adolescent. We need to clone Dr. Tripraneni many times over. And so we are concerned about our mental health clinician workforce, particularly in child and adolescent, particularly in psychiatrics. We've done work across the country with medical schools to incentivize emerging clinicians to choose this field. But it's a reality in our world. And so to the extent that virtual provides a way for access to happen that couldn't before, I think we have to take that very seriously, or we're going to be in a situation where demand is going to outstrip the available supply of providers. We talked about satisfaction for members and for providers. I think things that we see that are really positive and that I hear firsthand from providers that we work with at Optum Behavioral Health are that telemental health is efficient for them in ways that I wouldn't have thought about pre-pandemic. One, less no-shows. So people are much more adherent to their appointment schedules in a virtual environment. You're taking away the barriers of transportation. You're taking away maybe some of the scheduling constraints that would cause you to need to leave an hour before and after an appointment. And that's pretty compelling. Also, we note that our providers tell us people are more adherent to a course of treatment if it's delivered virtually. So that's pretty compelling too. And I'll be interested to see in the long term how that impacts healthcare overall. Because as people in the healthcare community, we are physical health, behavioral health, we're always trying to find ways to promote and treat and encourage adherence to care. And so I would also note, obviously, Commissioner, you talked about Senate Bill 3, which goes into effect in just a couple of weeks here in Maryland. And I think when we look across the country, and when I look across the country, the regulatory environment is certainly changing. I think an increasing number of states are taking the action that the legislature in Maryland has taken to take a very firm stand on broadening definitions and ensuring continued access post-pandemic, and really, addressing not only the need and demand, but what is clearly becoming the preferences of providers and people. So I would just say, looking into the future, continue to think about how we deploy this, how we think about and construct networks, how we think about and construct benefits with these new capabilities available to us. And I'm seeing as well such an emergence in providers that are operating only digitally. I've become acquainted with an eating disorder provider that works completely digitally, which has been great for children and adolescents and families to be able to access that within their home. So there are many studies out there. We continue to really drive for evidence-based care. I would agree with Dr. Chirruta, the audio only modality still needs some study, but we're pretty excited about the science and the evidence that's emerging, and the ability to potentially increase the use of measurement-based care through virtual modalities and virtual networks. So that's all for me. I got a lot of the same themes, but thanks, Commissioner, for giving me a few minutes to highlight them.
No, I appreciate that very much. One question, and we'll talk about this later, and of course, invite all of our registered speakers and others to give their thoughts on the questions that we've posed. But one of the things that we as regulators, obviously struggle with is, I guess the ultimate question here is, assuming you figured out how, like what counts, when
Right.
we're looking at the in some ways, the very heart of our struggle is about how to count it, and not just in terms of the weight to provide, but literally, operationally, how to count it. And so it's interesting to me. It's, Kaiser has an integrated model, so there's no disconnect between the providers and the payor, because they're integrated. But for an organization like yours, which is a fee for service model, or even an HMO context, it's different with your provider networks, your relationships. I want to stop hearing we can't do anything and get to the conversation around, because we are going to do something.
Yes.
And the question is, how engaged are we together in assuring that what we do is something that's going to work practically for everybody. That includes providers as well as carriers, and frankly, gives us data and gives us an approach that is ultimately going to benefit patients. So, one of the things that I want to consistently hear from carriers that are speaking is, as you're trying to solve this problem, because it is as much your problem to solve as ours, because you will have to deal with what we come up with, is how do you go about looking at the impact of telehealth capabilities on your network? I mean, you have the larger business concern of wanting to keep your customers, who are your members, happy, and wanting to retain their business and retain or grow your market share. So as you're making those considerations and thinking about not just telehealth and digital only programs, et cetera, which impact costs, but as you begin to think about, how does telehealth create opportunities for our patients, more flexibility? I'm interested in some of the metrics that you guys are using, because we may be able to use some of that as well. And it has to start with, what's available. What do your doctors have available? Who's using what, when, where, and how? So I don't mean to put you too much on the spot today if that wasn't part of your prepared remarks,
Okay.
but that is an area that we're very interested in, obviously, in hearing about.
I'm happy to make just a couple of comments, Commissioner, and then I'd love to have the opportunity to think with some of my colleagues a little more and come back to you. But I would say, to your question about what counts, that is the question. And so if we start with the clinical evidence, and I'll ask the clinicians who are here with us on the panel today to corroborate. We do know that the efficacy for virtual care for certain conditions and certain modalities is equivalent to face-to-face. So we always start thinking about coverage and counting with what the clinical evidence tells us. And there are myriad ways to count things as an insurer, right? We do a lot of math. We're good at math. So codes are a great way to count things. But I do think there is the propensity to undercount if you're just looking at codes and modifiers. And with the growth and flexibility and platform that was allowable during the pandemic, I think in some cases we have to really think about, are we sure we're getting an accurate read? It was pretty exciting for me to hear. I didn't know actually that Kaiser's platform is integrated right into the Epic EMR. That is pretty cool. But some of the platforms that we've offered, Doxy, for example, are different. There's a lot of platforms, a lot of modalities. So I don't have wonderful, tidy answers for you, but those are some of the things that we look at and things that we think about.
Thank you. I appreciate that, and look forward to hearing from you about some more ideas where telehealth fits in and how it gets measured and how it counts as
My
you
pleasure.
talk to your colleagues a little bit more.
I believe you're on mute.
David or Erica, did you have questions?
I don't really have a question, more of a comment. Just one of the things we are looking at in general and considering is, trying to find the appropriate balance between patient preference versus clinical appropriateness. And I just feel it's worth noting that when we're talking about behavioral health specifically, I think that's a more salient point, that patient preference may kind of be at a higher level where it's more closely linked to clinical appropriateness, because if it's someone with a mental health condition and they're not comfortable with a virtual visit and they want that in person, that's something that needs to be considered. And we're certainly trying to figure out how we can take that into account as we're coming up with these network adequacy standards. So that's something, we're certainly asking for comments for, from all stakeholders.
Thank you.
I just had one follow-up question. And Dr. Triparani talked about, as far as the patient satisfaction drivers, that they were looking at safety, speed, convenience, and quality. And then in your discussion, you noted privacy, as well as less no-shows and more adherence to a course of treatment. So it sounds like the patient satisfaction surveys are quite comprehensive. And I'm wondering if and to what extent improved wait times is one of those metrics that are included. And if so, what, again, to Commissioner Brain's point, what's being measured, how it's being measured, and how we can sort of be informed by that in terms of the regulations.
That's a great question. And as we think about access and adequacy, there really are a whole lot of different nuances that have emerged now with the rise of virtual that probably didn't exist when the original regulations were contemplated. So in addition to sort of general access, sort of how many clinicians are available in a geographic area, I do think that the presence of virtual, particularly in state where, if you sort of take licensure out of the picture, it does begin to call into question some of those typical geo access standards, right? Around how many providers are in an area to serve, a given number of people. And I don't know the right way to think about that, but I do think that there's probably some benefit to giving consideration to broader access where virtual care is available and appropriate, in the state of licensure. And I would also say one of the things that we're looking at more and more is in addition to availability, which is critical, and I talked about our concerns about workforce shortage now and into the next decade, time to appointment. So that's something I'm interested in too, is how quickly can someone get to care, and does virtual enable, and I think that's where you were going to, does virtual care enable a faster ability to see someone? And while I don't have data here at the ready, my guess would be it may depend somewhat on licensure and the level of practitioner and the level of intervention that you're looking for, but certainly something we should consider.
I can make a comment to piggyback on what Allison has said. Certainly in behavioral health realm, the virtual care has really opened up enormous possibilities to actually provide rapid access. I can even share some of my own personal experience. My clinical office is located in Shady Grove, which is in Montgomery County. And with virtual care, I could see a patient anywhere who is living in Maryland. In fact, we are tri-state licensure. Every single Kaiser Permanente physician is a tri-state licensure. In fact, I have seen patients who live in White Marsh or even Columbia Gateway. So we have behavioral health clinics there in those locations. It is possible that they may not have rapid access at that time. When I have rapid access that is available in my schedule in a virtual appointment, why should we have the patient wait to see a provider who may be practicing in Columbia Gateway? We have a child psychiatrist in Columbia Gateway, but here I am in Shady Grove. It really doesn't matter if I'm providing virtual care as long as it is clinically appropriate. So that has really opened up possibilities in providing even rapid access, breaking down these geo access boundaries.
I'm curious about the patient experience there as well. So, everything that I hear obviously is anecdotal. It's not, scientific. It's not, measured or, even necessarily validated. But, with regard to behavioral health, a lot of the anecdotes that we hear is that people are happy with it because they're able to get places faster. There are less barriers, blah, 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 blah. But have you found as a practitioner, or do you see circumstances where the opposite is true, where people really are concerned about being on the screen, or there's more resistance to,
Yes.
to David's point, where you see people don't really want to appear on screen? It sounds like we're going to hear some of that from Dr. Richardson as well.
In my personal experience as a practicing clinician, granted that I don't practice full time, I'm only a part-time clinician. I have never, not even a single scenario wherein a patient has expressed a dissatisfaction, and they were super happy. They were happy that they were able to get an earlier appointment, and I could do everything that I could. If there may be one or two circumstances wherein I felt the patient needed to be seen. For example, if we needed to do some computer testing for an adolescent for ADHD and stuff like this, I would redirect the patient to go to the nearest Kaiser Permanente Medical Center, which we were able to do it without any problems that is seamlessly coordinated. And my experience has been, I never had any concerns or any negative perceptions. In fact, they don't even ask me where I am located because I am virtual, and we only provide virtual care with wherein we have broadband connections on my end, so there are no video or audio interference at all. I found actually they're more appreciative of the opportunity to get an earlier appointment.
So we're going to hear from Dr. Richardson, but before we go there, I guess my one last question really for Allison, and teeing off of Erica's excellent question really is, when you all are looking, so you care, like we care about, the time to an appointment. That's something you're concerned about in terms of your providers and their ability to serve your members. So how do you measure that yourselves?
It's an emerging measurement, and I'd be happy to follow up with our network team with more specifics about how that's gathered.
Yeah, it's interesting to me. And, you know, we've always looked at sort of the surveying process of what's happening in the moment. You know, what do you have, you know, on which is, I mean, you know, frankly, you live and learn, but, you know, having a survey once a year as a data point has, you know, been less than, I think, helpful. I really understand the picture. But it also sounds like, you know, part of what you may be doing is also looking at historic behavior. And you seem to rely more on satisfaction surveys from your members. But I don't, as opposed to sort of our survey of providers in the moment, what do you have available right now? So that may be a different layer of discussion around what it is, what are we looking at? Are we backward looking? You know, should we be more backward looking and begin to look at utilization and look at satisfaction from the patient standpoint as we think about credit opportunities, as opposed to trying to survey what's available tomorrow. So I'm, you know, horrifying my entire team by throwing that concept out there. But as I'm listening to how you guys, as I think probably providers and also as carriers, begin to think about whether your networks are adequate, we haven't been asking you to provide historic experience and historic data, and to, you know, be more stringent in terms of satisfaction surveys with your members and what they have to say. And so as we're thinking about what is operationally feasible, you know, it may be that we need to be thinking in a slightly different direction. So
I think so. If I could comment, Commissioner, I think so. And I think the picture becomes a bit more complex when we start to factor in what's clinically appropriate virtually, what we know, what it's been demonstrated as clinically appropriate virtually by, you know, service line. Outpatient therapy is different than intensive outpatient, is different than partial hospitalization. So I think it could get pretty complicated pretty quickly as the science emerges, but that it's important.
I would say that I think that's extremely important. And one of the things that we have found through all of this is not always do people know exactly what they want and need. And part of that diagnostic component and really valuing that with the work of the clinician is key. Providing only one dimension to these services through telehealth is a failure to the patients.
Yep.
And I think that's one of the really important values when we look at this. As we get more sophisticated, this is a medium to deliver a range of services to a range of populations. And so that point of contact simply not being the same for everyone, but a diagnostic and informational support and ongoing navigation through systems, all that's really, really important. And I think a value that we need to expect from anyone delivering these services.
I agree. Well said.
that makes sense. Well, Dr. Richardson, let's turn to you, or Mr. Richardson. You are the Vice President and the Chief Operating Officer of Shepherd Pratt Health Systems. And I'm very happy to hear your insights and thoughts from the healthcare provider side of this issue. So thank you, and give you a chance to jump into this.
Well, thanks. And thanks, guys, for the time. And in the interest of not torching you further with the same information that our other colleagues did incredibly well, I'm going to touch on some other key points that I think are salient to this conversation, and then hopefully spend more time just asking questions and really being able to dive into more specific questions that you have. You know, us at Shepherd Pratt, we provide a range of inpatient and outpatient services for a range of folks with different sets of behavioral health needs. And I think one of the things we have to keep that in mind is that this is a specialty area that requires a range of services and diligence around that diagnostic component. You know, what I'm fearful of is that we utilize telehealth as a solution, not as a medium, meaning not every telehealth visit qualitatively is the same, even if the patient experience is good. I mean, so there's a lot of work that I think we need to look at when and who's delivering that service. How much of this is within both a virtual and ground ecosystem? So if someone is struggling within a crisis or needs a set of community-based services, how you can't virtualize everything, and really having a well-coordinated network of services that can provide that range of services, I think is really, really key. And I'll go into any depth in that as we go through this, but just to start off by letting folks know is that we have seen some of the same things everyone else has said. Patients are more willing and able to access care when the originating site is from their home rather than a facility, for all the reasons we talked about across different payer types. The logistics of getting care, waiting for care, and distributing care is exhausting. I just had knee surgery 2 weeks ago, and I can't tell you what a pain in the butt it was going from one doctor to the next, working out the logistics of doing all of this. It's enormous. And so anytime we can reduce that redundancy, we open up access and willingness to get care. I think the other part of that that's been really important in our space is, as both of our speakers mentioned, stigma is there. And anytime we can open up a way for people to understand and access care in the most least invasive way, that's why it has been a huge win through telehealth. For us too, we access to virtual psychiatric urgent care from patients' home has really done a great job about reducing people having to go to emergency rooms, wait endless hours for services. Our crisis walk-in services have been enormously valuable to be able to prevent that from happening. And so what we've been able to do is link people, either provide a set of interventions, try and admit people to an inpatient facility, or direct them to a range of services through that without someone ever having to show up in an emergency room. And so that, again, is another way to relieve that. And I think both of our speakers talked about the urgent care capacity of this, which has been enormous. For us too, distance to any of our locations is no longer a barrier. So, and what we've been able to do with that is really make care more accessible in other parts of the state that otherwise historically have been on the ground. So in Western Maryland, if we had a psychiatrist or a child psychiatrist who's available to see someone who's in Baltimore City, we've been able to provide that link and access, and then also ensure that link and access to care in those communities was still available. So the virtual component has been invaluable, and we have seen since March, the number for us has been about 500,000 visits. It's been pretty significant. But how we deliver visits and how we use those services based on the population we serve has been really, really different. And so I'll talk about that in a minute. And I just want to keep emphasizing that fact. There is our enthusiasm and the narrative that we all started with this is how quickly people pivoted to telehealth. The regulation and the regulatory relief has been enormously valuable. But over time, how we utilize this in a more sophisticated way and tie it to services on the ground with services in people's communities to keep that engagement is key. We can't simply provide an app and hope this works out, or simply provide services or make things look really cool. And I'll talk a little bit about that in a minute. We have, of the 500,000 visits that's only just for our therapy services, not other things that we do, 30% of those were audio only. So that number was pretty high. And that particularly was stratified within folks in Baltimore City and some of our Medicaid population who had very limited access to data on their phones or broadband. There's also a piece that throughout this has been so key for us, has been also helping people who weren't terribly literate in using these services. I mean, look how good we all have gotten at this from a year ago. And now we just torture each other with these meetings. But we pivoted quickly to this, right? If you have the right equipment, the right cameras, the right lighting, the right positioning, and you have families not competing for that same access in broadband. And, I think Dr. Davenport, you mentioned this earlier too, about just the issue around privacy. I mean, we work with a lot of families, and, the identified patient may not be, in a place to be able to talk privately, that, and being able to access those services in person and outside the home is really key. We do a lot of school-based counseling services, and the same. It is invaluable for us to sometimes get a window into what's happening with the family, but also it can stifle that really important private conversations that help the qualitative outcomes happen for these patients. I think the other thing everyone talked about a little bit earlier too was just the reduced wait times, because one of the things we've been able to do is really, if we had identified capacity in one part of the state, we were able to try and link people quickly for a telehealth encounter. That's been really important, particularly in specialty areas like we talked here about child and adolescent psychiatry, addictive services, eating disorder services, and some of our specialty areas. Getting that access regardless of where one lives has been key. I did want to go back to this conversation we had about broadband. We have spent a lot of time trying to look at ways to provide broadband accessibility, not simply for our services, but again, to conduct business in a virtual universe that we all live in now. We have people that digital divide is becoming more of a digital chasm that they'll never be able to get over unless we solve some of these for our entire states and countries, because we are asking people to do things with that vessel without the tools and equipment to make it happen. I think the only other things I wanted to just touch on that haven't already been discussed, because we've seen the same patterns around utilizations that Dr. Trippaneri discussed with Kaiser in terms of who accesses it, what demographically, how people are accessing it. We are using telehealth in a pretty diverse way. We use it for, as mentioned earlier, for crisis walk-in services. We also utilize it for homeless-based consultation services, where we're doing consultations with our treatment team for folks who are living literally under a bridge. And so being able to have that availability to provide consultative services has been invaluable. We use it a lot for our mobile teams. We have over 1,200 people in permanent housing across the state. During COVID, we were using it to do check-in visits to ensure people were safe. And some of the things that aren't terribly sexy, but show up in clinical efficacy, are people have food? Are they safe? The other thing that I think we've spent time on with limited success is that we have a number of day programs and day hospital programs, but that communal-based support that people get from each other. And that is one of the things that has been more lacking. I don't know if any of you have experienced this, but if you've gotten together with friends you haven't seen in 12 months, just going and touching them and giving them a hug and knowing that they're there for you has a huge qualitative impact. One of the biggest symptoms that we have seen during COVID that's propelled this misery that people will be in for a long time is isolation. And so how we respond to that and how do we utilize these tools and promote it is really key. So not just from therapist and clinician to patient, but how do we provide advocacy, recovery support tools? How do we provide self-support tools, both virtually and in person, together at the same time in a hybrid format are really key. We've done some remote patient medication monitoring throughout this, which has been a really important additive feature to making this work. So we have folks that their adherence rates are very significant because we were able to do virtual monitoring of their medications, not just their psychiatric medications, but many of the folks that we're serving are on significant other medications with major comorbid medical conditions. So that patient monitoring and medication adherence support has been a huge win in a lot of ways that we don't talk about. The other thing I just wanted to talk about was the staff experience. That you know, one of the things when the overall satisfaction has been high, for people being able to work from home and other places. But we are seeing burnout because of the demand in our field is exploding. The no-show rates, as several people have already mentioned, have been dramatically lower because it is much easier for people to get into appointments. But it is insufficient for us to maintain the success. I think we've done a good job. This whole continuum of behavioral health services, both virtually and in person, has to be the model for the future. Providing an app or counseling services or a teledoc service without a range of services available with a very sophisticated diagnostic delivery is going to be a huge problem if we stand these up without that infrastructure behind them. And so for me, there's been an advent. We've seen it because a lot of patients come to us after having been treated elsewhere, have been getting services through an app or some other service, and have felt once their level of need hits a certain level, they've not been able to get the supports that they've needed. So having that range of treatment services has been key. Being able to provide staff to provide home visits and ground level supports has been key. And having those ground level crisis services has been key. So I'll stop there because I think you guys covered a lot of other territory that I was going to discuss earlier, but I would love to just hear your questions and answer anything specifically. But there is no silver bullet here, guys. The answer is to offer everything and be more sophisticated about how we determine what services people need and make that part of the expectation for our payers and our providers.
Extremely helpful and insightful, particularly, your point around, the diligence that needs to happen about, what is clinically appropriate when, at what level, and across different areas of, medical or behavioral health needs, because, things that can be appropriate, in a, preventative care, seeing your internist. You tell how old I am that I'm using that word, my internist, versus, someone who is is having a severe, mental health crisis. So it's an area where it's just truly one size doesn't completely fit all. So that makes it that much more complex. But as someone who's here in the provider role, I'm very interested in your insights into what the data feed is or can rationally be between you and the payors that you're contracted with about when you're available and when telehealth is available. Because the challenge that we have here is developing a metric and a way of A, and then B, how to operationalize that. So whether it's telehealth or frankly anything else. But the concept of network adequacy, making sure that you have enough providers in the appropriate specialties and areas so that your members are able to get to an appointment within a reasonable period of time, within a reasonable distance, is something that we need to make sure exists. And so we have to find ways to measure that and what that is. And part of that, the complex, which is what we're working on and struggling with, and part of that component and what we're here talking about specifically today, of course, is where does telehealth fit into that equation? So how does it impact, the geography, and how does it impact potentially the wait times? What we hear over and over again from carriers is what can we realistically ask our providers to do? What are providers willing to do? So we have other speakers here today from other organizations that represent providers, but I'm interested in your perspective in that regard, because you have more things to do with your time than fill out availability surveys all day long.
Yeah, that sounds very captivating to do that, but no, thanks. I mean, I think that is a great question. I mean, I think depending, and this sounds like a BS response, but it depends on the patient themselves. There are some people that if we provided simply a virtual visit to them where they could meet with one of our counselors, that would be sufficient to meet their needs. And if we could provide that rapidly, that's fantastic. There is a larger set of folks that we're seeing now that both from a diagnostic and navigation need, they have no idea what they need. The level of acute needs is exploding. And so that point of access of meeting a counselor is an insufficient metric. What are the pieces that are available to get someone into long-term treatment based on that individual's diagnosis? In the same way that if if you're in an emergency medical situation, going to see a GP for an encounter virtually is not going to be sufficient. How do we help people identify the correct set of services that individual needs, and how do we move them appropriately, quickly to that level of care based on clinical efficacy is key. I think we would fail if we simply said we've provided access to everyone by meeting with a counselor, because we will needlessly move people through emergency services. During COVID, there's been such a promotion of, now we're seeing it nationally too, 988 is going to be coming online soon. We're talking about more and more expanding crisis services. That's great, but we can't move people from one crisis to the next, which is what we're doing right now. We need a more sufficient network of adequate providers who provide a range of these services and then can deliver on those outcomes rapidly. Dr. Rao mentioned earlier about the ability to see people quickly, not have to wait even on a crisis. But after that crisis visit, how can we ensure that person is getting access to the level of clinician and the set of services beyond seeing a psychiatrist or a therapist that will provide their ongoing recovery? So it's looking at clinical pathways based on diagnosis and level of the acuity level of that individual as they enter the system. And so, one of the things that's happening on the national level, the federal level, is really starting to look at crisis walk-in services in community-based settings for psychiatric crises. There's an advent of programs called CCBHCs, which are certified community behavioral health centers that require a set of services be available in a community to everyone who walks in the door, and to provide those in a way that they meet the needs of that particular community. Those are the kind of sets of ongoing services that mitigate the crisis to crisis services that both public and private payers need to work with providers to make happen.
May I add to that, Commissioner? Because I completely agree, Jeff, with everything you're saying. And from the perspective of a carrier, I have a very similar perspective. Jeff referenced their low acuity solutions abound today, and that is wonderful. And I think we as a community have done a lot of work to remove stigma around those. But as a carrier, similar to how Jeff thinks about it as a provider, it's incumbent upon me to ensure that my network has the full continuum to meet people's needs wherever they are, wherever they go, and however they emerge and present. So Jeff's points are very well said.
And so from a payer standpoint, I think our payers here should be expecting the providers to have that set of services that will help meet those sophisticated needs of those patients. And from a provider standpoint, we need to be able to have the sufficient resources to make those available. And so it is a common set of expectations that I think we share. We just have to figure out, I think, Alice, you said this earlier, you guys are good at math. We can be too, but we are all in this because we want to help people, and we need to figure out the right equation to do all of this. And I think part of this has to do with that level of sophistication on screening. And then I do think a tool that doesn't always get funded by every payer, which is, let's say I enter a Shepherd system, or not Shepherd's, another provider system. How can we help someone who doesn't understand the jargon and the misery that we put people through from one level of care to another? How do we help them navigate these systems more effectively and do this in a true advocacy, translational, transactional way? So that's part of these tools. And that's why it's really important when we look at what we offer people for behavioral health, is that we offer that continuum of care, and not some jargony way, but if I have a need, that I know what other resources will be available, and I can be sure I understand and have someone help me get to those points along my journey. Or we're wasting money, or we'll see the acute levels of need continue. The big push, and you asked me this earlier, we just opened a new hospital, and that's great. We'll never be able to build enough psychiatric hospitals if we don't solve what needs to be done at a ground level in our systems. So this is how do we deliver the more sophisticated set of tools to help someone identify what they need, ensure that network adequacy requires a set of services, not a service that's available in a community, but a set of services that will ensure efficacy in that community.
Well, thank you very, very much. Really powerful words by all of you, and helping us to also contextualize the importance of what we're doing. Because at the end of the day, what we're trying to do is make sure that people get the care that they need. Erica or David, questions?
No, thank you.
And not right now, thank you.
Well, thank you very much, Mr. Richardson. Very much appreciate the presentation and the perspective, because it's a critically important perspective, looking at it from the provider's point of view. So, thank you. And thank you really to all of our presenters today. You've given us a tremendous amount to think about. And if you have follow-up items that you want to send, comments, if there are things that you would like us to post, we're very happy to do that. Before we open up the meeting to the other registered speakers, just really wanted to take a moment to review the current approach to telehealth in our network adequacy regulations. The telehealth provision in the existing network adequacy regulations only permit a carrier to consider telehealth utilization as part of the carrier meeting the appointment wait time standard if a telehealth appointment is clinically appropriate and elected by an enrollee. Our proposal, which was included in the draft regulation that was posted to the MIA's website on November 4th, would alternatively allow a carrier to consider the offer of a telehealth appointment as part of meeting the appointment wait time standards only if a telehealth appointment is clinically appropriate, available, and accessible to an enrollee. So really there are challenges to both of these approaches. And frankly, what it all boils down to is, the operational reality and what is it possible for carriers and providers to be able to do, particularly based on sampling and surveys, and really, ultimately, how valuable is that exercise, and what does it really tell us about the availability of services just generally, but also particularly with respect to telehealth. So, what we, as I previewed before, and David mentioned as well, what we are continually struggling with is balancing out the reality of telehealth as improving access to care across most medical disciplines substantially. It's a great tool in many ways for preventative care, for triage, for follow-up, for monitoring, but it has to be clinically appropriate. It has to be accessible, it has to be available, and it has to ultimately be something that the patient chooses and is capable of engaging in at all kinds of levels, both literally in terms of having the right equipment and having the right, connectivity, but also being appropriate that they can actually engage and participate in a meaningful way, regardless of what the type of care we're talking about. And then, of course, it's getting down to the brass tacks, which is what metrics should we be employing? And when we talk about what counts, literally, how do we count it? So, what are the magic numbers? What are the percentages? And then literally and operationally, how do we get to that? So, we're all struggling with all of those questions. And, part of what we did in that regard was we posted a series of questions to the MIA's website on June 7th. And we're not going to really read through and walk through each of those questions now because they were intended to stimulate discussion on what type of credit towards satisfying the network adequacy standards a carrier should receive for having telehealth options available, and how and to what extent the regulations should take enrollee preference into account for both telehealth and inpatient services. And as our registered speakers speak, we certainly appreciate any of the thoughts that you have on these issues, the questions, the specific questions that we posted, the conversation that we've been having today. How are these measurements occurring? Should we be data mining and projecting? Should we be continuing this sort of looking at what doctors have available? What are the viable options that you see, both from a provider perspective for those of you that are representing providers, and from the carrier perspective? So what I will do is I'll call on each registered speaker individually, although some of you have indicated that they don't have prepared comments, only registered in case questions are asked or if they want to respond to something that's been said by other stakeholders. So as I identify each person, you can let us know. And if someone has not been able to access the link but signed up, when I call your name, if you're not actually sort of on one of our little panels here, just let us know in the chat room, and Craig can bring you over. So, and Craig has also posted the questions in the chat room as well, the ones that we posted on our website. So let me first start by introducing and inviting Ellen Weber, who is the Vice President for Health Initiatives at the Legal Action Center, to speak. Hey, Ellen.
Hi, thank you very much, Commissioner Bahrain, and we really do appreciate the opportunity to present today. And also, just again, it's almost hard to respond given all the wealth of information that was already provided today. And I guess for me, I will do my best. I mean, I had organized my information based on your 3 questions with some preliminary comments. I don't want to occupy too much time, but I guess I want to hit some high points if that works for folks. And again, I mean, all of this, so all of what we've heard today continues to give me the feeling of exactly what we said sort of before the legislative session. It just feels premature to make changes right now in the way telehealth services are counted for purposes of network adequacy, because we have gathered a lot of data, but we now need to gather data post-pandemic. And the post-pandemic data are going to be incredibly important to identify what we've all spoken about today. What trends are going to continue? Will individuals, and I'm speaking from the behavioral health perspective, will individuals with behavioral health needs want to continue in-person services, whether they want to continue a hybrid of services, or whether they will go via telehealth? And from everything, not only what Ms. Davenport talked about, but what Mr. Richardson talked about, is this is all going to be sort of a very individualized determination, and it's going to depend upon the acuity of the individual's condition. And at this point in time, given the escalation in need, as Ms. Davenport identified, and the acuity of those needs post-pandemic, we don't know, based on what we've seen pre-pandemic and or during the pandemic, what those needs are going to look like. And so to try to make any decisions without the data that we can now begin to gather, because the public health emergency has been lifted, it just seems entirely shooting in the dark. And so I believe that sort of is my major sort of takeaway message. I also do believe that that the legislation has in fact also kind of directed us to study this for 2 years and make some determinations precisely about the services that are needed and where individuals are getting that care. And then again, the MIA is also, as you mentioned, Commissioner Bahrain, required to take the legislation into consideration when making any revisions to the network adequacy regulations. And again, with regard to the legislation itself, it specifically says that a carrier cannot deny coverage for a service just because it can be provided via telehealth. And that means we are going to have to determine which services patients are electing to have as an in-person service. And the only way it seems to me that we can make some judgments about that is to see what the utilization patterns are over the next 2-year period. And then by making a determination about those by looking at those utilization patterns for different levels of care and different needs, both on the mental health side and the substance use side, then it seems to me some additional and much better informed judgments can be made. And so that, again, that was sort of where we started. I think that's where we're ending up. The legislation called for a 2-year study period, and we can't study what the need is if we don't have stable variables. And the stable variables right now are a variable that takes into consideration a patient's choice in service delivery. And if we change that variable at some point over the next 2 years, because obviously these regulations aren't going to be going into effect until partway through our study period, if we're all of a sudden changing variables, that to me undermines the study itself. And it undermines our ability to get at what we really need. And it's a real understanding of where patients want to get those services and where their needs are going to be most effectively met. Because we know, as Mr. Richardson said, and as Ms. Davenport said, low acuity conditions can be met perhaps very well via telehealth. But the obligation of the carrier and the obligation of the provider is to have a full network that serves a patient at the highest level of need as well. And that care is going to be needed to be probably in an in-person setting. So that, that is sort of how it sort of frames out to me. Another question that we have is we do consistently hear, and this is again during the legislative process and even in the materials presented, there's been this question about the fact that it's not possible to operationalize a patient's choice, what the patient elects for service delivery. And we would like to understand why that's hard to operationalize. Because over the past 3-year period in which carriers have reported out their use of telehealth, and CareFirst and Kaiser Permanente have done that, they have based that determination on data. And we suspect it's the utilization data that is the best proxy of what a patient wants. So the question for me is, why can't that same utilization data be used over the next 2 years to determine some proxy for patient choice? I don't understand why that's hard to operationalize.
Well, I think you're speaking to the difference between what is available today and tomorrow versus utilizing historic data, because they're utilizing historic data. They're looking at their claims data, they're looking at CPT codes. In some instances, they're pairing that with, satisfaction surveys, which have, utility, but are not complete, obviously. So that is the question that I was throwing out there. So, what we ultimately do in terms of, we can't suspend this effort for 2 years. We just simply can't. I hear what you're saying about the telehealth component, but let's just put that issue to the side and the impact of the study and what our conversations were with the legislators in getting to the final bill. But when we look at what we ought to be considering, if we come to the point of when credit should be given or how credit should be given and how we get to a place where what patient choice has been, because allowing for the fact that sometimes you elect something because that's all there is to elect. So there really isn't choice. But as we move out of a pandemic world and there are different drivers around that, it's intriguing to me, the idea of using the historic and the claims data as good indications of what utilization has been, what our patients. It doesn't tell us the whole story, right? Because it doesn't tell us what was available in that moment. It only tells us what happened. But telling us what happened is at least one valuable data point that is more meaningful and more exact than picking up the phone and saying, when's your next telehealth appointment?
I couldn't agree more. And I think that's why we come back to the importance of now studying post-pandemic trends, because those post-pandemic trends are now going to be able to assess the greater availability of telehealth services and greater experience and comfort from a patient perspective and from a provider perspective in delivering services in that way. But we'll then also measure, now that our society is reopening and in-person services are more available. And again, as we recognize the acuity level has increased and the level of need has increased, then we're also now going to be able to study what patients are getting in this new situation. So just as the old data is not sufficient to identify what's going to happen now, we really need to take a look at these new trends. And to me, the only way, again, the carriers are good at math. I would love to know sort of how they do this, but the obvious is looking at the trend data and looking at the utilization. And we have to do that post-pandemic. And so I find myself very much in the same position that Matt Celentano was in during the legislative process, requesting the opportunity to see the data post-pandemic. And given the acuity and the increase in need for mental health and substance use services, there's no greater need for that than now in order to really understand what happens. So I just wanted to, what is needed and what the best policy choices are going forward. That was the value of our 2-year study period. It was to try to maintain the status quo and then to be able to then make decisions based on that. And I really think that was the directive of the General Assembly. And for me, you can't measure what consumers want and what works for them if we take away the very ability to inquire about that. So if we remove the protection or the requirement that telehealth can be offered if a patient elects that, if we remove that in these regulations, then we really have removed any ability to say, carriers, we have to take a look at this, and providers, we have to take a look at this and actually measure it. You can't measure what consumers want if you take away the factor that allows you to measure that. And so that to me is what undermines our true ability to study and make reasoned decisions. So I think that's why maintaining that factor and measuring for it, and figuring out a way to measure for it is critically important. But the other thing I do want to mention is, in fact, the credit process that was proposed, again, based on Medicare Advantage plans. I mentioned this at our last meeting, but I think it's critically important to reinforce that credit in Medicare Advantage does not count to satisfying basic benefits unless the patient is informed and is given the opportunity to do an in-person visit. They must be informed that they have a right to do an in-person visit and given that opportunity, and therefore there must be sufficient numbers of in-person providers to satisfy that need. And so the credit in Medicare Advantage did not remove the ability for patients to elect the way they get their care. And so applying a credit in our situation, which doesn't take that into consideration, is just, you know, again, a completely different model. And as Dr. Permanente said, and I apologize if I mispronounced your name, as he indicated, patients at Kaiser Permanente are always given the choice to be seen in person. They are always given that choice. And so to me, again, the ability to study their Kaiser's data now post-pandemic, knowing that patients are given that choice, is going to give us a much truer picture as to what the trajectory really is and what the care services really are.
No,
So
I appreciate your points. We're pressed for time because we have, you know, lots of folks today. So I appreciate your comments.
I appreciate, thank you. And we will be submitting additional information in writing. I just want to say there are states that are now looking at this, and there are some states that are adopting a standard in which they will not permit telehealth appointments to be counted for purposes of network adequacy. And they also, again, reinforce the right of patients to have the choice of going in whatever mode of service delivery they select, in consultation with their provider. So again, want to reinforce that is also being seen in other states. So
Well,
thank
we'll
you.
look forward to that research and the materials that you submit. Thank you, Ellen, very much.
Thank you again for the opportunity.
Absolutely. So we also have with us today speaking Pamela Metz-Kasemeyer, who is with Schwartz, Metz & Wise, representing MedChi today. Welcome.
Hi, everyone. Thank you. And what a fabulous meeting. And thank you for all of the great information from the presenters. I thought it was an excellent range of all of the issues and give and take that we have in the current situation, which obviously is, as people have noted, going to continue to transition, and we're learning, and there's no like base, everything's the same to judge. So it's going to have to be fluid. I'm going to be very quick because I know the time ran out. On behalf of MedChi, I think a few real pointed comments on on the questions. One of the questions was relative to whether wait times and things could be assessed by having the carriers be required to contact the providers to get that information. It's sort of a mixed bag, I'm going to say, on all these questions. I don't know we have an absolute yes or no, but I wanted to raise some factors to consider. I don't think it's the contacting the providers that is overly burdensome, which I think some people have said. But I think it's that assessment would matter based on what the questions are you are asking. So is it average wait time for the practice? Is it average wait time for in-person, average wait time? Because if you have a practice with a range of providers, sometimes the wait time issues are hard to evaluate. You may have the best spinal surgeon in the country, part of a practice that also has multiple other providers. Well, that wait time is maybe going to be different than the practice overall. So I think the challenge in assuming that the provider community could help provide that answer is more related to the questions, and it really needs to probably be averages. If you're going to go in that direction, I'm not sure it will give you what you need, but there isn't an easy answer to that. And then there's also like acuity issues. Is it a wait time for something that needs immediate attention, or is it I need my annual something or other? How long will it take me to get in? Those are kind of different wait time issues. So I think the challenge, if you wanted to consider carrier communication with the providers to get that answer, is much more related to how specific the questions are or how you frame what that information is that's being gathered. And I also think the quarterly issue is probably way too frequent. It's not going to change. It's going to change, but it's not going to change that much. And so if you look at the demand side of providing that information, that seems pretty frequent. It's probably more like an annual or semi-annual kind of, if you were going to go in that direction. But again, I think it requires a lot of work on exactly what's going to be asked and why for it to provide useful information. And then switching over to that telehealth issue and the credits, I do think, and again, we don't have a yes or no answer, I think overall from the provider community. I think one thing we would say is if we're going to consider credits, it needs to be done concurrent with an ongoing requirement that the carrier demonstrated hasn't allowed them to stop trying to build out their in-person adequacy as well. The flip side of that is clearly there still remain areas and or specialties, whether it's geographic, specialty, others, where there's some real challenges with provider availability. They're just not there. It's not even that they don't. And so the telehealth, as we've heard from our presenters, has closed a lot of gaps in access for all kinds of positive reasons. And so I think there is a benefit to building that in and potentially with a credit. But once again, not to repeat myself, even though I am, you've got to make sure it doesn't allow them not to continue to be accountable for actual in-person visits, and to be able to demonstrate if they don't meet that, what are the issues that, why is that? And so it's not just, oh, well, I require telehealth there, so it's fine. But no, it's because we've tried A, B, C, D, and E, and it hasn't worked. So I think you need to marry the two together. And with that, I'll be quiet because it is getting late.
Okay, thank you very much. David or Erica, did you have questions?
No, I do not. Thank you.
I don't either, thanks.
Well, thank you. That's very insightful. It's also helpful to hear your perspective on frequency and the notion that, you're not going to see these big swings, in where practices are, on a quarterly basis, that there's a much more of a sort of evenness or levelness in wait times, particularly, and obviously, people are physically where they are. But, so thank you for that in particular. That's a very valuable point. So I will move to, we didn't see Daniel Shattuck, so I don't know if he's with us today. If you are, you want to throw, we don't see you in the panelist room and we haven't seen you. So I'll move ahead, and if you come on, if anybody sees him come on, let us know. So that takes us to Matt Celentano, who's the Executive Director of the League of Life and Health Insurers. So Matt, happy to hear from you today.
Good afternoon, Commissioner Bahrain. I don't really have that much to say, but I did hear from a little birdie that it is your birthday. So happy birthday.
Tomorrow, Juneteenth.
Tomorrow. Well, happy birthday tomorrow. But I like I said, I really don't have that much to say. I wanted to thank my colleagues at Kaiser and Optum and Mr. Richardson for really great presentations, and thank you for sharing your experience and giving context to some of these discussions. Carriers are analyzing a lot of things right now, as we've heard. The expansion of modalities, higher utilization, and trying to figure out what that new normal is going to be and what trends we're going to see now as the world sort of starts to get back to normal. So there's tons of considerations that are going into this. But we do understand, we have the questions from, I guess, June 9th. And we do realize that the tricky part is trying to figure out what counts and why it should count. And I promise you that the carriers are going to continue to huddle and try to figure out some substantial answers to those questions. And we will certainly be back to you in writing. So I don't want to take up any more time. Thank you very much.
Thank you, Matt. We also have, Kim Robinson from Cigna, the Regional Director of State Government Relations for Cigna. Kim, happy to hear from you.
Good morning, Commissioner and everyone on the call. Sorry that I'm off camera. I'm out of the office today, but I also, like Matt, I don't want to take up much time. I think that the presenters did a really good job highlighting a lot of the issues that we also are aware of, the experience that some of which is translated across the industry and other carriers. The one thing I will add, I would like to say thank you so much to Pam Metz for Case Meyer for her presentation just now. I think that when we talk about our concerns with the frequent contact of providers and whether or not we think it's burdensome, it really isn't that we have a problem contacting them. It's something that we do already. It's part of the accreditation for carriers where wait times are concerned. So we work with our provider partners to gather that information. It really was around some of the proposed changes, that frequency for one being one that we also were concerned whether we were getting the value for the increased contact with providers and worrying about what that was going to mean for their offices and whether we were really getting the juice for the squeeze. So I think it was helpful to hear it from the provider's perspective. And I also appreciate her thoughts around how we sort of marry the different requirements with the role that telehealth is playing. Certainly, we do experience the issue of lacking of certain types of providers in certain geographic areas of the state, and being able to take advantage of technology to close those gaps is really important, and how that plays into how a network is assessed. So I think that's an interesting point that she raised and a good ongoing pivot point for this conversation. So we will be regrouping with some of the feedback and working with Matt to continue to provide you all information. But thank you for the opportunity today.
Thanks, Kim. Always useful to hear from you. Deb Rivkin, Vice President of Government Affairs from Maryland for Care First. How are you today?
I'm great. How are you?
Good, thank you.
So I'm just going to touch on a couple things that I heard based on timing. Number one, we're all seeing that telehealth is an excellent option. That's the point of this. It's an option. And so I have to respectfully disagree with Ellen that the reg should be based on what the member chooses when we count for network adequacy. The point of network adequacy is to make sure that members have appropriate options available to get appointments. It's, to me, an option of telehealth visit, or right now an option of a phone call, as long as we have our 2-year time frame, is the same as an option when I have 75 offices in a locale. They're all options. I can pick Dr. A, B, or C. I can pick a telehealth visit, or I can have a phone call. And they all should be counted, not on what the choice was, but the availability of all the choices. In addition, I think it's important to think about, while this gets even more complex, is, and I've mentioned this before, we are required to reimburse a service that is within a provider's scope of practice, regardless if that's their specialty or not. So primary care physicians have the ability to do generalized behavioral health visits. They can prescribe drugs as well, just like a psychiatrist can. It's an option that a member would take to choose to go to their pediatrician or their GP for some behavioral health services. It will not be appropriate for all, and I understand that. But the point is, what we're counting are the options that are available to make sure that people have the most effective ways of getting a visit, and that's how it should be counted, not on what someone chooses. Certainly what they do choose and the data that we're collecting is going to help us understand what is working and what's not working, and where should we be focusing our energies, and what is good quality care. And I think this was part of what the speakers before were talking about. We need to see what people are taking. We've already seen trends change. We heard from Kaiser. It doesn't look like people are having as much satisfaction with phone calls as they are with telehealth. That is a bigger picture about what the world's going to look like for telehealth. I think a subset of that are the network adequacy regs, and I don't want to confuse the two. I don't think it's really, they're not the same. And so providing options is what's really important to me in this. And so the way I think your proposed reg is the right one. The telehealth, if a patient was offered a visit, that's what can be counted. Additionally, I just wanted to quickly, since it was the other issue that was discussed, is how often we talk to providers and the difficulty. I will tell you, we are calling providers more often because we have a lot of mandates and requirements now to call them. And we do need to figure out something that will be not burdensome on providers as well as to the carriers themselves. We have to call about directory updates, HEDIS information. I think there's new information we need to call now about the federal, what was it, the No Surprises Act. So when you call now and you ask these questions, what we're finding, and I totally understand it, what's the person's answering the phone saying, I'll answer one question. That's all I have time right now. You're going to have to call me back for another question, because they don't have the information in front of them. And so if we're going to be adding something to ask the questions about wait times as well, we're going to have to call over and over and over. So what we're finding is we call back and they say, you just called a day ago, we're going to answer one more. And then they finally figure out our caller ID and they stop answering the phone because they're too busy. And we need to figure out a way not to overburden and to make sure that we can hit all the metrics of all the mandates that we're required to do informational, to get the information provided. So I just wanted to add, I think that's why we're still thinking this through about what makes most sense in terms of timing, frequency, and what types of questions are asked. I think those are really the two biggest areas that we talked about today. So we are happy to continue conversations because we have other ideas as well, but I'll stop with that.
No, thanks, Deb. And we'll be happy to hear what your ideas are.
Yep. Thank you.
I see Kathy is also signed up to speak. Kathy Grayson, welcome back. Director of Government Affairs, Maryland for Care First.
Thank you so much, Commissioner. I actually will defer to Deb's comments on behalf of Care First, but appreciate the opportunity.
But mostly I wanted to say hello to you. So welcome back from maternity leave.
Thank you so much.
Our next registered speaker is Lori Doyle, who's the Public Policy Director for Community Behavioral Health Association of Maryland. So Lori, always good to see you. How are you today?
Very well, thank you, Commissioner. Pleasure to see you, and a happy almost Juneteenth birthday to you. This has really been an instructive meeting. I've learned a lot. The data has been quite remarkable to see, and the trends that Kaiser and others presented are very, very helpful in the discussion. I think in many ways, behavioral health may be in some ways significantly different from other kinds of healthcare when it comes to this discussion. First off, it's reflected in the higher privacy standards for behavioral health. We know there's been some access challenges, particularly in the commercial market for people with behavioral health. So there's already kind of a difference. But I think Mr. Cooney really pointed it out when he said that outcomes in behavioral health are largely driven by the client. If the client is not happy or comfortable, the outcome is probably not going to be a good one in terms of recovery from whatever the issue is. So in the old days, of course, everything was pretty much in person, and the client had a choice around whether they believe they need this particular intervention. Do I really feel like I need therapy or not? Or the type of clinician, I want a male or a female or whatever that might be. Now we're asking them to make choices about modality, and that's where telehealth comes in. We think it's very important to keep the in-person standard for now, at least, while we're looking at how telehealth is really going to work and play out in the market over time. And the reason being is because it could very well create a false choice. So if you have someone who comes and says, I need help, I'm in an abusive relationship, I need therapy, I need to see someone. And if the choice is you can get a telehealth visit tomorrow, but you're going to be doing that from home where your abuser is, and so you probably aren't going to want to do that, or you can have one in 90 days in person, which isn't a good choice either, because it's too far out, then what choice are we giving that individual in reality? And so this is the very real kind of thing that happens in the behavioral health world. There are real privacy issues that are involved that can be life-threatening in some cases. So we have to be sensitive to that. So I would urge the MIA to adopt and maintain the in-person standard. And as we look at how telehealth is working, and as we see if people are migrating to the use of telehealth, and if we use satisfaction surveys asking people, did you request an in-person meeting? If so, how long did it take to get one? We'll start to get that data set. And if it would get to a point where everybody's feeling comfortable with telehealth, gosh, it makes sense. We heard all the benefits that it provides, but there are still some significant issues. And again, I think behavioral health may be a little bit different in that regard. And I know this is a really difficult issue. I thank everybody for their time and work on this, and thank you for the opportunity to speak.
Thank you, Lori. Very, very, very helpful. And I do know that as we have, had these sessions and drilled down into these issues, that the concerns about, where the role that telehealth plays, not that it's unimportant in other areas, but I will say that the emphasis has really been from the mental health community in terms of being very concerned about how telehealth is going to play in to network adequacy. And we frankly have heard less areas of concern with respect to other disciplines. I don't know exactly why that is, but that certainly has been the case throughout these hearings. So thank you. Now we will hear from Mr. Craig Lippens, who's the president of the Maryland Addiction Directors Council. So welcome.
Hi, Commissioner Brain. Happy early birthday. I feel like now everybody has to say that. And I like that, though, because my granddaughter's birthday is coming up soon. So.
I'm not going to tell you the years.
I'm a gentleman. I won't guess. So I'm also the administrator of a behavioral health practice, One Promise. We have recovery housing in addition to PHP, IOP, and OP services. And I do think that I'm going to defer a lot to what Lori and Ellen said and others, because this has been a really wonderful presentation today. The one thing that I think needs to be hammered home is the importance of consumer choice. We have seen an increase in retention, an increase in completions, and better outcomes with the clients that are of a lower acuity, which is what we treat. I do think it's important that the option be continued of telehealth. There's a lot of anxieties, both from the providers and the clients, about coming back to in-person groups. In behavioral health, there are group therapy is the preferred modality for substance use disorders. And as the president of the Maryland Addiction Directors Council, all of our providers do outpatient group therapy. They're finding that the initial transition, not by choice, to telehealth was initially rocky. And then 6 months in, we did a survey of participants of substance use disorder programs receiving telehealth services. 93% were happy with the services being rendered via telehealth. This to me shows the need for us to continue that as an option. But I do think that the importance here is consumer choice. I frankly don't see it being very difficult to track whether or not a consumer has made that choice. I think it's essential that they be given that option, especially during this transition time. The adjustments people have made to telehealth aren't going to go away quickly, just like the adjustments to masks and vaccine and social distancing. And I think that, we as a practice and many practices continue to provide in-person services to the most acute patients. And we're very diligent about masks and hand washing and hand sanitizer. Good Lord, we bought a lot of hand sanitizer. But now that we're transitioning away, what we're seeing is that people are afraid. And I think to move too fast would really upset a very vulnerable population. So on behalf of the MADC programs, the addictions programs, we encourage that the patient choice continue. It's fairly easy to track, and it has been very beneficial for those that are transitioning to sobriety and recovery. And I definitely thank you for the opportunity to speak on behalf of the addictions programs. We're like the subset of behavioral health that often doesn't get a voice. So it's nice to be able to speak up and say, hey, don't forget about us, because we're a very important segment of the behavioral health providers. So again, thank you. Everything's been covered. I mean, Dr. Rao was wonderful. Allison was encouraged to hear about that. But I do think that the continuation of it and the study of it will prove that it is a valuable alternative, but it needs to be the patient choice. And as far as clinical determination, once you identify somebody as having a substance use disorder, then their path of recovery has to be a collaboration. You have to get buy-in from the patient or they will not engage. We used to say that they would vote with their feet. You know, if they don't like it, they'll vote with their feet. They will go somewhere else. Now they'll vote with their clicks. They'll just click off and go somewhere else. So thank you for your time. That's all I had. Everything else has been said and said well.
Well, thank you very much. I appreciate that. I think your comments are well taken. Your concerns are well taken. Erica or David, did you have any questions?
No, I do not. Thank you, Commissioner.
I don't either, thanks.
And last but not least, in terms of those who are registered to speak, we have Glenda Lindsay, who is the Public Policy Coordinator for the Maryland Academy of Nutrition and Dietetics. So welcome, Dr. Lindsay.
Thank you so much. It's a pleasure to be here today. And as the Commissioner said, and I thank her for allowing me to speak, I represent the Academy of Nutrition and Dietetics. And I also am representing Barbara Hofstein. She is our regulatory person, and Dan is our lobbyist. And she asked me to make some comments, as well as some other dietitians to make comments on the questions. And what I kind of focus on the preference of enrollees versus the clinical appropriateness. And I took into mind that when I was trained as a dietitian, as well as a public health practitioner, we always looked at, we were trained to look at the individual. And so that made me focus on that point. And I would also add that if we look at COVID-19, and we learned from COVID-19, during, and post COVID-19, that we must focus on the populations in terms of each population group is different, as well as the social determinants of health. Now, the social determinants of health, as most of you know, includes income. And when I talk about income, I'm talking about the poverty level, unemployment, food insecurity, which we focus on quite a bit in the Academy of Nutrition and Dietetics. Also, it looks at the geographical location or where a person lives, and that plays into network adequacy because where a person may live may prevent them from going to that institution, the hospital, the clinic. And I have seen that as practice as a dietitian, and sometimes people do not keep the appointment. And the mere fact of going back to another social determinant of health, the income. Sometimes they do not have the money for gas, as well as other travel modalities. And so that has to be looked into. And quiet as it's kept, even the educational level. Some people have a problem dealing with the healthcare system because they feel their education level is not adequate enough to communicate with providers, even dietitians. For example, I had a patient who didn't want to see me as a dietitian, and it was mandated that she see me, but she didn't want to see me because she thought she was not educated enough to convey what she needed as an individual for herself, as well as her children. And then once she saw me, she became more comfortable. And also, another part of social determinants of health is even marital status. And I have found as a provider, and one thing I must add too, I do this on a part-time basis. I also am an adjunct professor at Morgan State University and do quite a bit of other things. But some of the dietitians in our group, which we have about 1,200 in the state of Maryland, some of them do it on a full-time basis, and some here to represent it as well. Now, as I was saying, that even marital status, sometimes people who are married, they support each other. And so when appointments are needed to be, they need to make their appointments, the husband or the wife support each other. And so, and if it's travel time with that, it may be good or it may not. And so if it's on a telehealth, it's and comes into play, then the person, each individual will have upon them their obligation that they're going to make that appointment. Now, in my, as I said, I do it on a part-time basis with the patients that I see. I have found that they keep their appointments, as I think some others have mentioned. It seemed to me that their appointments are met, and they keep the appointments at a more regular basis, because sometimes in the office I have sat there and I have to call them. I said, do you remember your appointment? But they show up on Zoom, so that's a great thing. And I think they feel more comfortable with that one-on-one communication on the Zoom or phone call, more so than they do in making it to an organization. I think if we as providers and healthcare and the healthcare insurance institution should take into consideration the relationship between health disparities and the social determinants of health. They are so closely related. So in the past, the preference was on the side of, and not putting the insurance company down, because we do need them and the providers. But sometimes we do not look at what the patient needs. And I think that's so important because again, I'm a registered dietitian, doctorate in public health, but I also teach family and consumer science that's looking at the family. And I see that all those three, I feel blessed that I'm in all those disciplines, because all those three, I see that we need to look at health disparities, social determinants of health, and how we deliver care to various population groups, and not only minority groups, but groups, urban versus rural groups. I'm working on a study now on looking at the external pressures of the family. One of the persons that's involved in the study with me, she's in a rural area, I'm in the urban, and they are different urban area, and they are different perspectives of how people who live in rural as versus urban areas and how they look at healthcare. And so again, COVID-19 showed us there was health disparities. They were based on social determinants of health. And we do not want to, years from here, end up with the same thing of health disparities, saying, what can we do that we knew prior as public health practitioners, we knew prior to COVID-19, they were some of the main issues facing many communities, especially communities of color. And so we must consider some of what they go through and what we go through as providers and insurance institutions, what we go through dealing with people with different ways that they deal with the social determinants of health, including income, geographical location, marital status, the healthcare access to healthcare, along with the built environment. And so pretty much that's all I have to say. But again, we as dietitians, we are very active in, as the public policy coordinator, and we have a whole panel of people who deal with legislation. And so we are very active in trying to make the community a better place, and we provide care for the people that we serve. So thank you so much for allowing me to be here today to represent the Academy of Nutrition and Dietetics.
Thank you, Dr. Lindsay. Very insightful comments, particularly on, all the ways in which things are interrelated. And we can really see the strength of your disciplines, as you look at these issues. So your insights are extremely valuable, and we thank you for them. I don't know if anyone on my team, David or Erica, did you have follow-up questions?
No, Commissioner, thank you.
No, thank you.
You're welcome. Thank you.
Very, very thorough presentation. Thank you, Dr. Lindsay.
You're welcome.
And I understand that Dan Shattuck is here now. So Dan, would you like to comment? I don't know if you've heard any of the presentation and sort of got knocked off, or if you wanted to comment on the 3 questions, but just wanted to give you the opportunity since we do have some time.
Oh, thank you very much. And I had to jump off for a minute, but I just wanted to thank everyone, and I'm glad that Dr. Lindsay was able to give her comments. I know that this has been for a lot of the clients that we represent, and the dietitians, nutritionists in particular, telehealth has been just a valuable tool for them to continue to access their patients and for patients to access them. And I think it's just important, again, and I appreciate the MIA and your thoroughness and really investigating this topic and in the broader context of network adequacy, and really trying to come up with a framework that's going to work best for insurers and for patients and providers. I'm just going to leave it at that. We may be submitting some written comments later on, yeah, I just want to say thank you for that, and more to come.
Okay, well, thank you, Dan. I appreciate it, and we will look forward to receiving your comments. That is all of the, those are all the folks who were registered and to speak, plus our panelists. Are there any, and I don't see in the chat room, but are there any unregistered participants who would now like to provide any comments? If you would like to do that, this is your last chance to identify yourself so that Craig could unmute you. And so that's Ann Geddes saying yes, if there is time, there is time, and we're scheduled to go until 1 o'clock. So if you'd like to speak, Craig, perhaps you could bring her over.
Yes, I just brought her over.
Okay. So please.
All right. Can I be seen and heard?
Yes, absolutely.
All right. Thank you. Thank you, Commissioner Brain. Thank you for giving me this opportunity to speak, even though I was not able to register in advance. My name is Ann Geddes. I'm the Director of Public Policy with the Maryland Coalition of Families. MCF provides family peer support and navigation services to families, to parents caring for a child with behavioral health needs, and to families with a loved one with substance use or problem gambling issues. We have about 60 family peer support specialists across the state who work directly with families. And I just felt like I need to try to speak for some of those families. A fairly obvious point that for many of them, telehealth was a real failure, particularly families with young children. I interviewed and I was trying to get families to be able to testify today, but they were unable to devote the time needed this morning to do that. But I did interview them, a number of them. They had, for the most part, young children, 8, 7, and 5. And I think that it's important for us to remember that network adequacy is a real issue for children with behavioral health issues already. And during the pandemic, with only having the option of doing telehealth, children, one of them was had a diagnosis of autism spectrum disorder. One had a diagnosis of ADHD. The other was trying to get a diagnosis of autism spectrum disorder, but the doctor did not feel like she could make that evaluation based on what she was able to observe through telehealth. The children would not stay engaged. One mother talked about chasing her son around with a laptop so that the therapist could observe his behavior. That was just untenable. There was one who whose child had ADHD, and he would make faces on the screen and then leave, and the therapist couldn't get him to engage. The mother could not get him to stay on the computer, stay seated in his chair. And this represents, lost learning time. For these families, it's been, over a year now. None of them have yet gone to in-person services. They're all waiting to go back in person. And it's been critical developmental period that they've lost learning time. In addition, the one who was waiting for a autism diagnosis lost the ability to apply for services through the Developmental Disabilities Administration because she did not have that diagnosis, that the doctor did not feel like she could give through telehealth. So I just wanted to make the point that for children, especially young children with behavioral health needs, for many of them, telehealth has not been successful, and the families are impatiently waiting for when they can go back and receive in-person appointments. Thank you.
So just to be clear, this is an issue that sounds like maybe it's not entirely, but it's primarily driven by the pandemic and the absence of the ability to have inpatient. And the warning signal here is that it's presented sort of an unintended experiment in the efficacy of telehealth for certain services, particularly with regard to children with certain needs. And so that you've been able to observe so that as we come out of the pandemic and inpatient or in-person appointments become more available, I think what you're cautioning is that telehealth is rarely, if ever, going to be a viable alternative or a clinically appropriate option for that type of patient, that type of situation.
Precisely. That's precisely the point I wanted to make. And the need for choice and the consequences of not having choice for a timely in-person appointment.
That's very, very helpful insights. And I'm sorry we didn't hear from the families, but if there's a way that you want to condense some of that information, in a way that obviously protects their privacy, we'd be happy to see that as well.
Yes, I will be submitting that. I have more detailed stories.
Thank you very much. Was there anybody, Erica or David, did you have questions?
No.
Anybody else who is in the chat room? We still have a few more minutes. All right, seeing none, let me just take a second to see if Erica or David have any questions or any comments that they'd like to make at this point with respect to any of the panelists or speakers, or any comments that they would like to make from today's presentation, today's meeting.
I do not, Commissioner, other than to thank all the speakers for the helpful information and context. Thank you.
Yeah, same for me. You all have certainly given us a lot more useful things to think about, a lot of information we can dig through. So we appreciate things. Thank you everyone for your participation today.
Yeah, absolutely. I'll echo that. I think that today's session was extremely useful in many, many ways. Lots of really good insights, lots of really good data. This is our last public meeting with regard to the regulations that were published back in November. And so the MIA staff will be meeting internally to discuss all of the information that we've received, all of the comments that we've received, and we expect to make additional revisions to the draft, and we will, when that's concluded, publish that to the MIA's website via the network adequacy email distribution list to get to the point where, and we'll make the determination at that point. I think it's quite likely that we will probably pre-publish and have another hearing after the next set go out there. So that's at least the current plan. I don't have a time frame for you, but that's at least the current process. So again, thank everyone for their participation today. Extremely helpful, and also just really nice to see all of you. So that ends our presentation for today. Just a reminder that the recording will be posted to the MIA's website at insurance.maryland.gov in the next few days, along with any of the materials, the slide presentations that are provided to us that we're given permission to post. So thank you to everybody, and that will wrap it up for today's session. Thank you very much.
Thank you, Commissioner.
Thank you, Commissioner.